My name is Peter Ranspaw, and I'll be discussing a case of persistent phantosmia following the resolution of COVID-19 illness in a 59-year-old male. Phantosmia is the experience of smelling an odor that isn't actually present in one's environment. It's also known as an olfactory hallucination. It's associated with migraines. It's actually considered to be an aura when discussing migraines. Phantosmia is also associated with temporal lobe seizures, brain tumors, and importantly, upper respiratory infections. How common is phantosmia in COVID-19? Well, a very recent multi-center European study showed that about 86% of their population of patients had some sort of change in smell during their COVID-19 illness. Of those who had changes in their smell, 13% had phantosmia. How long did it take for these patients to recover? Well, in those that did recover by the time the study was performed, a little less than 3/4 experienced full recovery of their sensory symptoms within 8 days of resolution of COVID-19 illness. Meaning it's reasonable to expect, if you are going to recover your sensory symptoms, to recover them within the first week or so. Although, of course, there's cases of such symptoms persisting for much, much longer. So what are these patients smelling exactly? A study performed from 85 to 1995 by the Taste and Smell Center in Washington, D.C. Kind of gave us an idea of what most of these patients smell. And the answer is it's usually foul. About 34 smell something fecal-like or rotten. This is 34 out of about 125. 70 out of 125 smelled something chemical-like. And burned or smoky smell came in third place. So how do we treat phantosmia? Usually we don't. We kind of just observe and treat them conservatively. There have been cases where medications have been used, a wide array: antipsychotic, anti-migraine, anti-seizure, transcranial stimulation, not widely used, nor is topical cocaine application. Venlafaxine is one of the more common medications used, not particularly effective. What was particularly effective, and still is olfactory mucosa excision, although this is pretty invasive. The end result of this procedure is complete loss of smell for the rest of the patient's life, but hopefully the resolution of their phantosmia. And a systematic review performed in 2008 of the relatively few amount of these procedures that was performed showed that 10 out of 11 patients had at least short-term relief of phantosmia following the olfactory mucosa excision. You can see a pathology slide here showing neuromas as well as a higher incidence of immature neurons in these olfactory mucosas excised from these patients as compared to a normal olfactory mucosa. Let's move on to our patient. His first day of illness started with fevers, shortness of breath, a dry cough, body aches, fatigue, malaise, and of course he tests positive for COVID-19 that same day. We move forward 17 days, and all of his prior symptoms have resolved, but now he has a sinus headache, mild congestion with a little discharge, and he constantly smells burning cigarettes. This waxes and wanes throughout the day, but it never remits and never changes in character. We move forward 2 months when he finally comes in to be evaluated. His symptoms are unchanged. Still has a sinus headache, still smelling cigarettes. Sinuses were non-tender. Looking into the nares showed irritated, friable mucosa in both nares. Pertinent past medical history is really limited to a surgery for septal perforation 20 years ago, hypertension, coronary artery disease, and obstructive sleep apnea. So what do we do for him? We gave him oxymetazoline, really for the congestion and drainage, and we ordered a non-contrast brain MRI. He had a headache, and there have been case reports of olfactory bulb lesions and even intracranial necrosis seen in patients with anosmia following COVID-19. We move forward another month to day 108 of illness. His MRI is negative, and the ENT agreed with our treatment plan. He is still being treated conservatively and will continue to follow. So what can we do moving forward? We can use this increase in these kind of cases to improve our understanding of the pathophysiology of phantosmia. We can characterize common clinical courses in order to educate our patients correctly, and we can analyze data regarding treatment efficacies. Here are my references, and I thank you for your time.